And this is the calculation tool where you need to put first the country. You need to put the country depending upon which country you are. And then you go on adding your age, sex, weight, height, previous fractures, parent fractures, current smoking, steroid intake, and then you put the BMD that is there. That will give you a calculation which tells you what is the probability period for the next 10 years. There are additional technologies that are available to make a diagnosis, but I think most of the time BMD or the X-ray is almost straightforward. Management, general recommendation, and pharmacological therapy. General adequate intake of vitamin D and calcium. I think let's not even forget that let's start with the basics. 1000 milligrams of calcium to every person aged 50 to 70 years, and if it's female is about 1200 milligrams. We have to understand that with this itself, we can generally increase the incidence of fracture to a large extent, almost to 30 to 40%. Vitamin D, 800 to 1000 international unit per day for adults aged above 50 to older. Somehow or the other, in a country which has got so much sunshine, the incidence of vitamin D deficiency has been seen very, very high in this country. We're not sure why, or was it not even looked at it. A lot of people said it was probably marketing device, but the fact remains, a lot of people have started coming with kind of pains which after treatment with vitamin D tend to reduce itself. So what we need to understand that we need to ensure that we have to have a strengthening exercises. We need to have a therapy for all our patients, like a fall prevention program that is to be held. In our rehabilitation center, we do that. Tobacco and alcohol usage may be difficult for people who are already in it, but I think we need to do it at some point of time. So, exercise, calcium, smoking, reduce alcohol consumption, fall prevention program will definitely determine the outcome of your spine and hip fracture in the future. For the pharmacological therapy, I think every postmenopausal woman and men aged about 50 years and older must be considered for this therapy with the following, if they have following things. Vertebral fracture or a hip fracture, a hip DEXA or a lumbar spine T-score less than minus 2.5, T-score between minus 1.0 to 2.5, 10-year probability of hip fracture of more than 3% based on FRAX, and 10 years probability of major osteoporosis-related fracture of more than 20% based on FRAX. And all these are very, very important. And hence, when you are going to fix a fracture next, and any patient, and we get plenty of geriatric patient that comes to us with a fracture, I think we not only must treat the fracture, we must treat the cause of the fracture, because it has been found that 20% of the patient, they come back to us. If you have treated one hip fracture, 20% come within 1 year, and almost 40% come in the next another 1 year. So within 2 years, you'll see almost 40%. So unless you really treat them very aggressively, you will get this patient back within 2 years. The therapy that are anti-resorptive or anabolic, and anti-resorptive bisphosphonates have remained and will remain the standard treatment along. And alendronate and resendronate has been the pioneers for us, and most of us have given weekly dosage and has gone for some period of time. Other things like abandronate, zoledronic acid, calcitonin, estrogen, HRTs have been given selectively with varied kind of results. PTH has now come into being for the last few years, has given excellent result in most of the patients who are osteoporotic. So I would consider the first line as alendronate or resendronate or zoledronic acid. Alendronate will remain still the first line simply because it is easier, better, faster, and much more convenient to most of the patients with once-a-week therapy. Zoledronic acid, very, very popular in United States because it's once-a-year injection, 5 milligrams. But you need to be careful, especially with patients who have got renal problems. Ibandronate has not been found to be very useful for fractures around the hip or in the forearm, but probably in the spine, it allows us some kind of good results. Just to keep you awake at 10:15 or maybe 10:30, here's lady, not necessarily need to be Hema Malini, 62-year-old lady, 5.4 height, 60 kgs, 10 years post-menopause. Oh, she should have got an DEXA spine T-score -2.5 and a hip score -0.16. I would look at the audience, what would they like to do for her? Anyone? I'll give a little more history. Her mother suffered hip fracture in her 70s. She performs a weight-bearing exercise 3 times per week, non-smoker, rarely drinks alcohol, take 1 calcium supplement each day, unknown dose, consume no dairy products and no vitamin D. How do we treat this lady? Anyone? Just want to keep it a little more interactive. And she's also worried because of the family history. She's asking you, what is the next step? What are you going to do? Anyone? Beg your pardon? Vitamin D3 with calcium. Yeah, here, what you need to remember is that here is a lady with a family history of fractures been already there. And she's already -1 to 2.5. So I think we need to be a little more aggressive. You look at the picture, do you see anything in the picture which is very, very nice? At least let's look at the picture, if nothing. Forget the osteoporosis for a moment. Anything? That's a problem with life. You see a beautiful lady and you only look at the car. The problem is, osteoporosis is like that. It's very silent like a beautiful lady. It doesn't come in. But when it happens, then it badly shatters you totally badly, so you do not know what to do. So most of the time, our orientation is towards the fracture and not to the cause of it. And this accident has happened because of this lady, because he probably was looking at her and driving, which happens to most of us. That's why a lot of billboards should be avoided when you look and drive next time. So what is important is, we must really identify which are the patients which are high risk. And that's very important. And for that, you need to know the history and some of the things that they have, and are they on what medication. Each person is an individual by itself, and we need to assess them, and we need to have a strategies for each of them separately. That could be non-pharmacological, pharmacological, or both. So the guidelines are very clear. For every person who is between T-score -1 and 2.5, anywhere a diagnosis of a hip or a spine fracture with a DEXA score of less than -2.5, or a FRAX which tells us more than 3% for hip fracture, more than 20% for major osteoporotic fracture, you have to treat this patient energetically and very aggressively. So we come back to this Miss H. Her lab test was normal. She considers us and chooses an anti-resorptive like allogeneic. Does fairly well starting once a weekly for 3 months. After that, she fails to take the medication. Over the next 7 months, she often misses her weekly dose. And that has been the problem for most of our patients, because adherence to the treatment of osteoporosis patient has been the most difficult task, and making the people take the treatment has been very, very difficult, because none of them feel anything until they fracture the bone. And if you look at that, once you start the treatment, the rapid drop in non-acceptance due to various reasons has been phenomenal, and that has been one of the major issues in the treatment. And hence it's very important in a management of osteoporosis, you need to talk to the patient at a very long duration, counsel them why is it very important that they need to take the treatment. But what is good enough is, whenever a good clinical trial was done, where there was a good adherence for almost 80%, there was significant reduction in risk of fractures, both vertebral and non-vertebral, where in the real world, where you and I live, up to 83% of the patients are not adherent to osteoporosis treatment. And so this is caused a serious consequences by increasing the number of fractures. And when you look at all our practice in orthopedics, basically now we get all elderly patients with osteoporotic fracture. So why do these patients resist this? Because probably lack of knowledge, lack of skill, and perhaps they never understand the problems they're going to get into. And you must remember, a woman's risk of a hip fracture is equivalent to a combined risk of breast plus uterus plus ovarian cancer. So serious it is, and yet we fail to recognize this major problem. There are newer agents that have come, denosumab, which has come now, where you need to take the treatment once in 6 months. Very good for patients who has got renal issues. So if you look at medication, alendronate helps both spine, hip and non-vertebral, same as risodronate. Ibudronate, if you see, it helps in the spine fractures but not really helpful in hip and non-vertebral. Zoledronic acid is good, but needs to be very, very careful. Lot of contraindications have come in, and in the United States, it's very, very clear that in patients who has got any kind of renal condition, you need to be very careful when you give zoledronic acid. Denosumab, yes, good subcutaneously, okay, but the results still needs to test of time. Teriparatide, very good in severely osteoporotic patient. So we need to individualize this treatment depending upon on what the patient has got. Newer agent has come like strontium, and there has been a 37% reduction in vertebral fracture of 3 years, 43 after 5 years. Supposed to be good, but now the FDA has not approved it, but in Europe, some of the countries really go for it. Romosozumab is coming in now. It is still not FDA approved. Parathyroid, you all know PTH. We are talking about so much about it, but newer drugs are coming in, and this is supposed to be better than the PTH that we use, and supposed to be reduce the major osteoporotic fracture by almost 55%. Other drugs, cathepsin K inhibitors, this was a trial which is a multinational trial, and I was one of the primary investigators in India, which has happened in 3 centers. But I think odonacatib has been stopped because of the increased risk of stroke. Conclusion, more and more drugs will come in, but there is no ideal drug that probably could be given for any good patient. So I think we'll have to do it as per the patient. There has to be a reason of how do you treat the patients. You don't treat the fracture only, treat also the cause of the fracture. Bone density remains the most valid and the reliable measure of fracture risk. FRAX is the new imaging approaches to look at the health of the bone. Bisphosphonate has been the mainstay, but has its problems, and so we talk about stopping the bisphosphonate after 5 years, giving it some holiday period, and then start continuing. Teriparatide, excellent, but cannot be given for more than 2 years. There is a need for drugs that could happen, and I think we are talking about innovation today, and this probably the topic that we are having requires more and more innovation, so that in the future, most of us, when we become old, we have something that we can take it easily and will give us an adequate treatment. So we are waiting for the youngsters of today to come up with novel therapeutic tools to counteract the osteoporosis epidemic. Dr. Prabhu is the president-elect of the Indian Orthopedic Association, and he is like, I'm trying to follow him to become also, and I am also standing for election this year. And anyone who is an orthopedic surgeon who has not voted, ensure that you got last 1 week to vote for this particular IAOA. If at all I have to become the president-elect and I have to follow Ram Prabhu. If you do not, please do not vote. Thank you each one for giving a patient hearing, and thank you Cadilla for giving us this podium to talk on. Thank you one and all.
It was surprising to know that even if they combined 3 drugs, many patients tolerated it. We thought when they had atenolol, ramipril, diuretic, we thought we were scared. But even a moderate 160, 90, 180, 70, 90, 100 patients could tolerate one polypill is a great thing, but it's a compliance because you take one drug. And another controversy, whether to give in the morning or the evening, it is not solved yet because the newer 2-3 which are the some of the research article came up saying that evening dosage of the blood pressure medicine would be more beneficial. But earlier we were saying early morning because the early morning surge of the blood pressure is 4 a.m. to 8 a.m. is highest. So with that combination of blood pressure medicines like an A, B, D, or sorry, A, C, D, or one of those 2 drugs, and that gives a great combination because combining reduces the side effects and increase the great compliance in these people. That's why multi-drug fixed dose polypill therapy is going to be one of the important things when you see these people being, and the new surgeons of chlorthalidone, the diuretic, which is a long-acting and as well as doesn't cause so much hypokalemia or hyponatremia as we thought of hydrochlorothiazides. I think beta blockers are almost gone because a lot of trials. Only one drug which can be used nowadays is because the nebivolol, which can be having some 3rd generation beta blockers, we call them, little bit of vasodilating effect. Except that atenolol, metoprolol should not be preferably used unless there is a compelling indication of angina, heart failure, stroke, or hyperdynamic circulation. These people can be used. And there are many other things which we keep on discussing about the SPRINT and the HOPE trials. I'm not going to deep details. With this new trial which came up just last year, or this year beginning, is that about systolic blood pressure intervention trial, SPRINT trial, where non-diabetic patients were intensively reduced to show that whether the primary outcome was different. Not really. So the intensive treatment arm had a 25 lower risk of primary outcome, but still we have not taken the SPRINT trial into all the guidelines. Overall benefits of more intensive exceeded the potential for harm. So is there any role for that? But many of the studies have shown that this method of blood pressure measurement yields substantially lower readings than the single rush measurement in the typical many practice we have. So should we really adhere to less than 120 or 140 we are still able to conclude, but not all the patients can be part of the SPRINT trials. Another trial which was a part of the trial is a HOPE-3 trial, wherein among the patients, the intermediate cardiovascular risk with a normal or lower BP do antihypertensives reduce CV events. You could see that the curve was not too different and no significant difference in individual components of outcome were seen in these patients. I'm not going to detail in this, but as we go on to see that, so is lower is better, like LDL cholesterol, lower is better we know, but not true for hypertensive therapy because blood pressure is it's multifactorial, so it should have enough compliance for the treatment as well as should not have side effects. That's very important when you're treating blood pressure patients. In special cases like in diabetic and in CKD patients, of course, we need to have a little bit stricter criteria of 130 systolic of 85 diastolic. It's shown in our CORD trial and many other trials wherein the goal for the BP is little different in CKD and diabetic patients is also shown there. The same thing was shown in the JNC 8 as well as the other guidelines. So I'm not going to do details. As we know. Trials, so it's morning and evening, as I told you, is still in debate. One of the trial of MAPEC trial, they thought that lower CV events were seen when you put them in the evening, but it's still not very acceptable because it was a limited trial of limited patients. And morning, to conclude, hypertension remains a condition of public health in India, which is a silent disease. It's called a silent killer. And method to measure the BP, accurate BP, should be given the due importance. That's, as I told you, very, very important. And ambulatory blood pressure is a useful tool in certain indications, especially like resistant hypertensions, to diagnose a very labile hypertension or white coat hypertensions. And although recent trials have provided useful information for lowering BP, further, usual goals of BP should be followed. That means the physicians who have been practicing for more than 40 years will know what is correct for the patient, and the BP goals can be lowered in some special situations, populations like CKD and diabetics. And choice of drugs for controlling should be individualized, I told you, not that everybody can tolerate ACE inhibitors. So, till more data emerge, evening dosing of the antihypertensives can be advised, but we have both the things we have been doing morning and evening. I think it's high time that India has to have its own CV outcome trials. I in fact, invite O.P. Singh Saab to have more cardiology. I was just discussing with him, invest more into younger physicians to come back with a strong, because we have very, very less data among Indians. Thank you so much.
Thank you, sir, for the great speech on management of hypertension. Ladies and gentlemen, now we are open for the discussion. If anyone have any question regarding both the session, our medical dignitary will be happy to answer them. I welcome Dr. Naresh Shetty and Dr. B.C. Kalmat on dais. So please, sir.
No, because on the behalf, as Suzanne. So we can ask from there. We have an understanding that we'll ask only one question each other. So, Shetty Saab, a lot of elderly patients, I mean, at home, we never bother to, do their BMD, our mothers, our aunts, fathers. But is the fracture incidence lesser in India than the Western world? Is it less or is it same?
It's definitely not less. For the fact remains. We tend to exercise less. We tend to be more sedentary in lifestyle, and we don't seem to be treating, especially our ladies, don't seem to understand, because a lot of people go with some kind of a vague concept that taking calcium causes renal stones and otherwise, that is the factor. And then also some of the cardiologists also tells them, don't take calcium, can cause, this is what they come, this is what some of the things that are coming. I think what we require is to educate our people a little better than what they are actually, including our parents who don't seem to understand. They think just drinking milk is more than enough. I think they'll have to have tons of milk to really reach the calcium level which is required.
Tired of taking calcium, most of the elderly.
They come and ask, how frequently should I take calcium tablets? How long? Can I stop after 1 month or should I continue? As you said, calcification, when we cardiologists say your arteries are calcified, suddenly somebody would jump and say, no, he's taking a lot of calcium. That may be the reason why.
Exactly.
And even our statin, they mentioned atorvastatin calcium. So there are people who question us whether that calcium is going to cause calcification.
Yeah, unfortunately, it's all the wrong concept that comes about, because that word calcification, thing is because of calcium. That's the problem actually.
In the past, most of the vitamin D preparations were with combined calcium in it. And of late, I don't know, with new fashion, we just have pure vitamin D preparations. We have pure vitamin D preparations without calcium added to it. Any reason for it?
Well, it's just the convenience that is there. Though I think the amount of vitamin E that's available with the calcium is much less than what is required. So I would certainly suggest that you need to look at this combination is the only one thing that's happening in India. Okay, and I would strongly believe that the amount of calcium that's required, so in average we are talking about 1,200. An average requirement of calcium is about 1,800, and you can take it from your nutrition that you take is about 500 to 600 to get. So the makeup that is required is about 1,200 for all the ladies that are put together. So and that's the reason we talk about 2 tablets, which none of us give it to our people, because they think one calcium, ek to kuch aur kuch problem ho jayega, bolke they don't take it. But adequate, just to create that bank, you require at least 1,000 to 1,200 calcium. And if at all you do not have enough vitamin D, the calcium absorption will not take place. So it's almost kind of a waste that you take in calcium. So I think both the things needs to be considered. We need to load people on vitamin D, at least for some period of time, between 4 to 8 weeks, depending upon how much they have got vitamin D. I would strongly believe, again, getting a vitamin D3, which is expensive, you might as well give them vitamin D. No problems have happened because of excess of vitamin D. Problems have happened because you do the test and the patient feels very expensive. Might as well give them the calciferol a little more, 4 to 8 weeks. There's no harm done. Because we are talking about 30 nanograms and all those things. You can go up to 50 with anything. There is absolutely no side effects that has been seen so far with an excess of vitamin D. So better to be safe, give it nicely, and then I think the calcium as appropriate as per the age group, I think, give it.
No question. I just wanted to comment. With the present scenario of money, calcium which is going in the blood, people take serum calcium level and they say it's normal, so I don't need to take. This is a current account which goes in the blood, and the bone calcium is a fixed deposit. So we must have an adequate fixed deposit to have bone to be safe. Okay, just to have a current account, that doesn't mean that your bones are safe. So your addition to the calcium to the person, whether parentally or in the form of oral, will actually get deposited in the bone. So your serum calcium level is not really an indicator of having proper calcium. So that you need to really remember, that your fixed deposit in the bone has to be good. Then only your bones. And that's the reason why people, those who are osteoporotic also, will continue to have serum calcium levels normal unless there is some pathology there. Okay, there is some hormonal problems or parathyroid problems, etc. So you need to have that as a thing. So BMD or a DEXA scan is a gold standard to really find out if there is a deficiency of this osteoporosis which needs to be treated. That is extremely important.
Yeah, I second what he says. Just because your serum calcium levels are normal does not mean anything at all. I think we need to understand that that has got nothing to do with what is actually used. He is a typical Bombay financer. He was talking about fixed deposit, current deposit, and all those things. I couldn't do that. And hats off to, again, that's why he's known as the financial capital, because he's trying to make you understand in that.
One small, a lot of people are confused between, if people are not vitamin D deficient, can they become osteoporotic? No,
100%, without a doubt. Okay.
What's the relation?
See, all of us are going to become deficient over a period of time, whether you like it, and especially women. The hormone, once that effect is not there, that's the first starting point where it gets. In adults, males, they're a little lucky. It might happen 2 or 3 decades later than the females. But the female predominant, and I think actually the osteoporosis start much before even the menopause. Okay, so that's what is a very important aspect, which is a part of our changing and aging, and we need to be careful much before that.
One more. Sorry that I am taking the mic away from you, Naresh. Other thing is that if you are normal walker or mountaineer or whatever, that doesn't mean that your vitamin D is normal. I'll give you my instance. I do regular mountaineering. I walk a lot. I exercise a lot. So I never thought that my vitamin D would be deficient. And I started getting some hip pain, and I got my X-ray done as usual. X-ray didn't show anything, so I got my MRI done. MRI showed that there was some kind of edema in my hip. And then that made me do my vitamin D, and I was really surprised to see my vitamin D was 5, which I never thought that it would be. And it took me 6 months. I, of course, took a lot of vitamin D, and then it took me 6 months to get rid of that pain. And I became almost about 50 plus, as Dr. Naresh Shetty said, that 50 is a good indicator that you are not vitamin D deficient. So it's important that we, as a routine, get your vitamin D done. And some people, especially the ladies, post-menopausal, I think it's important that you get your DEXA done. Because prevention is the best way to avoid fractures. And if you are good, the likelihood of fractures are reduced to almost 10 to 20%. Even if you have a fall, you may not have fractures. So that is important, that doing DEXA, even for male osteoporosis is also as common, not as common as females, but it is also there. So all of us need to do our DEXA at least 45 years to 50, and there is a genetic predisposition. So if there is fracture,
there's no duration, you need to take throughout. But all the bisphosphonates, today we talk about 5 years and maybe a holiday period and then start it off. That means you give a holiday period of some period of time. We are talking about parathyroid not more than 2 years, because someone said, why 2 years, why not more than that? Because we do not have a clinical data which tells us that after 2 years what happens. Like bisphosphonates, suddenly they saw spontaneous fractures happening at the end of 6 to 7 years, and that's why now we're saying give a holiday period. So we do not have a data for that, and that's the reason why we keep on putting it. So as we advance and as we learn more and more, I think things might change over a period of time. But this time remains calcium and vitamin D standard, cannot change at all.
Yeah.